Welcome to this Thursday morning edition of Cancer Corner. And with us this morning, Dr. Todd Scarbrough, radiation oncologist with Alabama Cancer Care. And Dr. Scarbrough, good morning to you.
Good morning.
Good to have you with us.
Tradition out of this.
Yeah, and next week we want to kind of whet your appetite a little bit. Next week we're going to be taking your phone calls live here on Cancer Corner, and any question you have about cancer beginning next Thursday morning, Dr. Scarbrough will answer those questions. And so if you have friends who have dealt with cancer, or maybe they're cancer survivors, or just finding out they've got cancer, or just general questions, you make sure you call us next week here on Cancer Corner. Well, today, Dr. Scarbrough, we're talking about breast cancer and its treatment. A little overview of this morning.
Mm-hmm. Yeah, breast cancer is well, first of all, it's one reason to talk about it is such a common cancer. Mm-hmm. Women are at a high risk of breast cancer, obviously, to the tune of about 1 out of 8 women over the course of their lifetime are at risk for having breast cancer. It's
That's
the most
pretty
common.
high.
Yeah, right. It's the most common cancer among women. It's not the most common cancer killer. Lung cancer is the most common cancer killer among women, but it's the most frequently diagnosed cancer in women. And it's a big worldwide problem. Obviously, it's a big national health problem. We were just talking before we came on air. You've known people who've had breast cancer. I've known people who've had breast cancer. My mother had breast cancer. Have had close friends in church and at work who've had breast cancer. So I would wager that everyone knows somebody who's had breast cancer. And again, it's just one of those subjects that is so common, and so many people have experienced it. We could do 100 shows on breast cancer and not cover everything that there is to know about breast cancer, and all the we've had shows where we've talked about cancer myths and urban legends and things, and breast cancer is one of those that is just rife with urban legends, and someone has known someone. And let me give you my opinion about what breast cancer means and what you should do if you've had breast cancer.
It's a very survivable cancer.
It is very survivable. If you look at, breast cancer, to me, and I say this to people very often, it's probably the most studied medical question in all of medicine. We have done so many trials in breast cancer, and it really is, if you look at just the history of surgery, which surgery has, in terms of like its modern application, modern thought, maybe about 100, 150 years old. One of the first surgical questions that were ever asked were questions about breast cancer and what should we do for breast cancer. And back, if you look at, like all things in medicine, but breast cancer really has had an evolution over the last 100 years of how we treat it and approach it. If you look at 100 years ago, how we approach breast cancer, they did something called a radical mastectomy. And a radical mastectomy meant basically they would not only remove the breast, but they would remove most of the lymph nodes up under the armpit. They would remove the muscle on the surface of the chest along with that as well. So it was basically an idea of pretty much everything in this region of your body, let's surgically remove it. It was a very disfiguring operation to a large extent. Very difficult to recover easily from. But that was the idea back then, that we had to, and notice that word, radical mastectomy. It was radical. If you hear that as just a person walking down the street, radical, it's kind of a scary word. And I hate that too about medicine, that we use some words like that, which have such a bad connotation. We're trying to explain one another doctor to doctor sometimes, and we come up with these words, and again, I hate that sometimes that we don't have a better word to use for the general public. So we would do that 100 years ago, and that was the idea, that you had to have a radical mastectomy if you wanted to beat breast cancer. The idea being that you would have to remove all this additional tissue. And then around the 50s or 60s, some people started thinking, well, it looks like even though we'll do these radical mastectomies, the breast cancer will still come back in another part of the body, in the liver or the bone or the lung or something like that. So what sense does it make to remove a quarter of a person's body if the cancer is going to come back? So there's an idea of about a local idea of breast cancer versus a systemic idea of breast cancer. And that's when our thoughts about breast cancer began to change. If you look at 30 years ago, we still had the idea of we should do a mastectomy, and maybe that's the best thing for breast cancer, but the idea was coming on at that point in time, let's not do a radical mastectomy. Let's do something called a lumpectomy, which is just remove a portion of the breast. So that was a huge thought change in medicine, that we're just going to remove a portion of the breast versus a mastectomy. And if we just remove a portion of the breast, how are we going to make up for, so to speak, that mastectomy? We're going to do radiation to the entire breast versus remove the entire breast.
And that's a great emotional rise for that woman who is facing breast cancer.
Yeah, and going back to my idea that it's the most studied question in all of medicine. We probably have, 50, 60, 70 randomized trials looking at between 500,000 to 1 million women of looking at this question of, is a lumpectomy equivalent to a mastectomy in terms of survival, in terms of cure rates? And nowadays we can say with a very, very high degree of confidence that when a doctor chooses a lumpectomy in the right situation versus a mastectomy, it has probably not only equivalent survival and equivalent cure rates, it may have a slightly better survival overall. So maybe that's one of the first things I would mention if I'm just talking to someone who's just been diagnosed with breast cancer is you don't have to immediately go to the mastectomy. Some women think, okay, I just want to cut it off. Even though we've talked about, we've known people where, they've faced the emotional ramifications of having their breast removed and think, I'm not as much of a woman, etc. But really, the idea of getting a lumpectomy and not having a mastectomy is a very, very, very safe decision. Like I've said, we've studied it in every which way that we know to study it. And it's a very, very safe option to choose. Now, the idea, we kind of got into the thinking about the treatment. We've talked about mammograms and what women should do to look for breast cancer. But even getting ahead of that, and this is something I'm just now getting into in my practice, it's something that we're all just getting into in medicine. I don't know if you noticed in the news a few weeks ago, it just came out that Medicare is now approving genetic screening.
I saw that.
For everyone now. And of course, to be on Medicare, you've got to be an old person. So they're basically saying they're approving it for older people. But private insurance is now, and has for some period of time, approving that for people. And so why would you want to get genetic screening for cancer? Why would you want to get genetic screening at all? You can go on websites like 23andme.com, and they'll send you a kit in the mail with a swab, and you basically just swab it inside your mouth, and then you drop that in the mail, and then in a couple of weeks, they give you a sort of a book's worth of data about your genetic code and what you may be at risk for. Now, things like 23andMe right now, which is just an off-the-shelf, they can't give you all of this cancer genetics, but actually about 4 or 5 or 6 years ago, they could do that, and then the federal government shut that down. But you can go to your doctor and get a genetic test. And again, it's just, they just swab a Q-tip inside your mouth and they get some cells and send it off, and they look at your 4 billion base pairs of DNA inside every cell and give you some idea about your genetic risk. So if you, I'm going to say this directly to the camera, if you have a breast cancer, if you've been diagnosed with a cancer under age 40, or if anyone in your family has been diagnosed with a breast cancer under age 40, it's probably true to say that you should go get genetic screening for cancer. And it's an easy test. If you have health insurance, it should be covered. It's to some extent slightly expensive. I think the test costs upwards of between $500 to $1,000, but again, insurance should cover that. But it gives you so much information in the right situation that now we're becoming proponents of that. And this is something called precision medicine, precision targeted medicine that's coming on the scene. If you want to, I'll be actually in the clinic tomorrow here in Sylacauga.
Okay.
So if you have, like I said, if you had cancer diagnosis at a young age, or anyone in your family's been diagnosed with cancer at a young age, come to Sylacauga tomorrow and we can do the genetic screening test tomorrow.
That's right there on James Peyton Boulevard in Sylacauga. And Dr. Todd Scarbrough, radiation oncologist, with us this morning. Different types of breast cancer and the treatment thereof.
Yeah, so most breast cancers are what we call invasive ductal carcinomas. The other broad subtype of breast cancer is a lobular carcinoma. They probably, as we get smarter about breast cancer and cancer in general, and we're doing more genetic testing, we'll probably realize in the future that they're very different entities. We already know that to some extent, but we treat them very similarly, so we sort of say they're different, but we treat them exactly the same. In the future, we may not treat them the same. But most women get diagnosed with an invasive ductal carcinoma, and of those invasive ductal carcinomas, then we have a lot of different ways that we subtype past that point. We look at the grade of the cancer. The grade of a cancer means that a pathologist will look at it under the microscope and give us some ideas about how aggressive it looks under the microscope. Then past that point, we'll do actual molecular tests on the cells, determine if they're hormonally sensitive or not. That's a big deal in breast cancer. We'll then determine if they have any other molecular features, which is sort of a genetic screen in and of itself of the breast cancer, talking about something called HER2-neu. If you have been diagnosed with a HER2-neu positive breast cancer, you know intimately what that means. We used to say, I actually had a friend in church who called me up a few days ago, and his wife has just been diagnosed with a breast cancer. So he was telling me all the features of her case, and she had been diagnosed with a HER2-neu positive breast cancer. Now, I remember when I was in medical school, and I was in medical school from 1994 to 1998, when we had at that time, and it was just something that we were beginning to look at that point in time, that you were diagnosed with a HER2-neu positive breast cancer back then, we knew it was a very aggressive breast cancer. So he's telling me that his wife was just diagnosed with a HER2-neu positive breast cancer, and her doctor told her it's an aggressive breast cancer. And I said, well, kind of, yes, that's true. Without treatment, it's an aggressive breast cancer. It's a more aggressive subtype of breast cancer, but we now have a targeted treatment for HER2-neu positive breast cancer that the prognosis of it now is better than non-HER2-neu, if you understand what I'm saying. That the drug now that we have that's targeted toward that cancer is so phenomenally great, and it's really one of the miracles of modern medicine that we can target things like that. And when the trials first started coming out 10 years ago now, the breakthrough and the improvement that we saw with HER2-neu targeted therapy for HER2-neu breast cancer was just phenomenal. It almost gave me cold chills when I would look at the data, how great that it looked for these breast cancer patients. So I told him, not really an aggressive breast cancer, because the drugs that we have and the treatments that we have are so great for it. So that's one thing we look at as far as the types of breast cancer. HER2-neu, is it estrogen positive? And then we have, if you're not estrogen positive and don't have a hormonally sensitive breast cancer and don't have a HER2-neu breast cancer, there's another subtype of breast cancer we call triple negative breast cancer. And that truly is right now probably one of our more aggressive subtypes of breast cancer. And by triple negative, we mean that it's not estrogen positive, it's not progesterone positive, and it's not HER2/neu positive. And we don't have a lot of great drug options for those patients. Then we look at subtypes of breast cancer, so we have all those. Then we have the stage of the breast cancer past that point. So are you ductal carcinoma? Are you lobular carcinoma? Are you grade 1, 2, or 3? Are you estrogen positive or are you HER2/neu positive? And then what stage are you? Are you stage 1, 2, 3, or 4? So a woman can have a breast cancer, and just think about all those things I just listed right there, and then we could actually subtype it even more so than that. You know, you could have basically easily right off the bat 100 different subtypes of breast cancer. If you look at the stage, if you look at the estrogen, if you look at the HER2/neu, and if you look at the grade, and if you look at the subtype past that point. So then we basically look at all that, and then we decide how are we going to treat you.
Obviously, we could talk about this for a long, long time, and maybe we can talk more about it next week. I want to remind you that we'll be taking your phone calls here on Cancer Corner next Thursday morning at about 7 o'clock. And you can ask your questions and invite friends to join you for the show next week. And with Dr. Todd Scarbrough, a radiation oncologist. Final few moments, let's talk about the causes, the symptoms, and the diagnosis.
Yeah, so the cause of breast cancer, going back to genetics again, about 5 to 10% of all breast cancers have a true hereditary basis, we think, and hopefully we can pick those up in the future with genetic screening. But most cases of breast cancer are what we call sporadic, which means just we don't know the cause, and it might just be sort of a random event inside the patient's body. So when we go out there, like for lung cancer, we say, well, smoking causes most lung cancers, and that's true. I can't go out there and say what causes most breast cancers in women. That's why it's so important to get these things like genetic screening if you have a strong family history, or once you get age 50, or perhaps age 45 or 40 if there are other histories in your family, you go and get this mammogram routinely, either every year or every 2 years, depending on what your doctor recommends. So at that point, we hopefully have picked up breast cancers, and then they present at an early stage. And if you present with an early stage breast cancer, it may just be your symptom of breast cancer may just be the mammogram. In other words, you have no, I haven't felt a lump, I don't feel sick, I have no complaints whatsoever. I'm just going and getting my routine mammogram every year, and they found a spot in the mammogram.
That's why that's so important.
That's why it's so important, absolutely. That's cancer screening for the population. So I'm going to give you a sort of a vignette of the average patient that I see in my clinic. They have been doing the right thing. They've been going and getting annual mammograms. They saw a spot on the mammogram, and then they go and see a surgeon. And the surgeon says, okay, we're going to stick a needle in that and get some cells. They stick a needle in there, very simple in-office procedure, and they see some cancerous cells in the needle. And then the doctor comes and discusses with the patient and says, we're probably going to recommend a lumpectomy for you here because we've caught it so early. We don't see any spread outside the area. We don't see any spread to your armpit. So then they go and get the surgery, which again is usually a lumpectomy. And one thing that we do differently now, which has been a great breakthrough for patients, is they'll just sample 1 or 2 lymph nodes under the armpit, not a big surgery at all. And so then this patient will come to me and likely still have a stage 1 breast cancer with no spread under the lymph nodes. And then we'll probably recommend some radiation after that. And assuming that they don't have the HER2/neu type of breast cancer, which is a rare type, only 1 out of 4 breast cancer patients have a HER2/neu positive breast cancer, and that it's estrogen positive, we'll recommend 16 days of radiation, which is easy. You just come in, lay down on a table, and it's like getting an x-ray every day. It takes about 10 minutes, nothing touches you, you don't feel anything. You've had a simple outpatient surgery a month or 2 earlier where you didn't even have to stay in the hospital and had a small incision on your breast. And then you get these 16 days of radiation therapy, which again just take about 10 minutes a day, and you do whatever you want during that entire treatment. You don't get sick from radiation, you don't lose your hair, you have no external signs that you even have cancer to people that you meet out and about on the street. And then you take a pill, an anti-breast cancer pill, which is a hormone pill, for about 5 years after that, and you should have a 90 to 95% chance for cure long term.
Wow. Dr. Scarbrough, we talked about the age factor. What about black, white, Hispanic? Who does it affect most?
There probably are differences there with certain other cancers. Prostate cancer, for example, in men usually presents with a higher stage and more aggressive. But as far as we know, there's not a huge difference there on the breast cancer stage broadly with African American versus Caucasian. But there are certain groups, in particular certain Jewish sects, Ashkenazi Jews, we say, which most people don't even know what that means, but many Jews are Ashkenazi Jews, and it's a certain region of the that's over there in the Middle East, have a genetic and very hereditary basis for their breast cancer. But in general, no, there's no big disparity there, black versus white, in terms of breast cancer. Otherwise, can't think of anything else to say about that besides just whether you're black or white, go and get routine mammograms. Now, you could be black and let's say your mother had breast cancer and your grandmother had breast cancer and your aunt had breast cancer and you get diagnosed with the breast cancer, that may indicate a more genetically aggressive type of breast cancer. Whereas if you're white and you get breast cancer at age 50 and you have no one in your family that's ever had breast cancer, maybe not as aggressive breast cancer. On the other hand, if you're white and again the same family history and you have a grandmother and a mother who's had breast cancer and perhaps a sister who's had breast cancer versus if you're black and you have breast cancer and no family history, it's not going to probably be as aggressive.
Now you'll be in Sylacauga tomorrow?
I will be in Sylacauga tomorrow. So again, if you have any significant family history of cancer, please stop by the clinic tomorrow. I should be there all day tomorrow, and we'd be glad to see you and do this. It's actually a very simple test. And if you've been thinking about getting a genetic screening and you have a strong family history of cancer of any subtype, colon cancer, gastric cancer, I mentioned gastric cancer. There's one genetic screening that we do, and we do it when we do the genetic screening. If you have this gene for gastric cancer, we're now recommending entire families get stomach removals, their entire stomach removed to prevent gastric cancer.
Wow.
And that's how earth-shaking some of this genetic screening can be. You come in, you get a test, you're found to have the gene for gastric cancer, and usually the genetic test is not the first indication. You've had maybe a father who had gastric cancer at age 50 or something like that, it being your indication that you need to get screened for it. But yeah, come in, get it, we'll do it for you tomorrow. We'll have the equipment and the packs there.
So on James Peyton Boulevard, Dr. Todd Scarbrough, radiation oncologist. He will be at the office there in Sylacauga tomorrow. Offices across the state of Alabama. Don't forget, next week we're going to be taking your phone calls, and maybe we can talk more about breast cancer and answer your questions. Dr. Scarbrough, thanks for being with us this morning.
Thank you. Always a pleasure.
More Daybreak right after this.